Good evening, everyone, and possibly good morning for Dr. Mazen. Tonight for us would be a sweet day. So, meaning that we're going to talk about diabetes polyneuropathy, which is concerning us as neurologists. As we know, diabetes is well known. It's very common here, at least in UAE. We are estimated at least 25% of population who are suffering from diabetes. Nevertheless, diabetes polyneuropathy is also a common complication of diabetes. Uh, Today will be the talk will be more recent updates on uh, diabetes polyneuropathy diagnostic criteria and symptomatology, which is going to be done by Dr. Zulfiqar Hussain. And the next topic will be done by Dr. Mazen Dimashqiya on recent updates on treatment of diabetes polyneuropathy. The next session will be, or the second session will be done by the Dr. Amr Al-Salti, Dr. Wael Mustafa, and Tamal Al-Salab. So the first session will be done by Dr. Zulfiqar Hussain, who is a staff neurologist in Cleveland Clinic Abu Dhabi and neuromuscular specialist. He is practicing neuromuscular service by doing nerve conduction studies, needle EMG, and intraoperative monitoring in Cleveland Clinic. Dr. Zulfiqar had his residency program done in United States, as well as his fellowship. He had also his fellowship done in intraoperative monitoring and neuromuscular diseases. His talk today will be updates in diagnostic criteria and clinical symptomatology of diabetes polyneuropathy. Dr. Zulfiqar, the microphone is yours.
Issues, but good evening, everybody. If it's a good evening for some, obviously attendees, and maybe for the others, is a good afternoon. And basically, I'm going to start the talk, and my discussion is going to be a update on clinical presentation and diagnosis of diabetic peripheral neuropathy. So basically, as Dr. Abubaker said, I'm going to start with the first half of the discussion. First of all, I really thankful to the MCO and Dr. Abubaker to give me this opportunity to talk today on this evening. So I will start with the learning objectives. The learning objective, the prevalence of diabetic peripheral neuropathy, to understand the clinical presentation of diabetic peripheral neuropathy, to identify the associated risk factors for diabetic peripheral neuropathy, and also to discuss the utility of laboratory testing and diagnosis of diabetic peripheral neuropathy. With reference to this discussion, I have nothing to disclose. So, as you know, that the diabetes is basically a group of disorder. It's abnormal metabolism of carbohydrate that cause hyperglycemia. It can be a multiple reasons, but two main reasons. One can be due to the deficiency of insulin. That can be due to the autoimmune destruction of the pancreatic beta cells. And the other reason can be a resistance of the insulin, or it can be a combination of both.
Sorry to interrupt you, doctor. Can you go on full screen?
Oh, okay, sure. Go on full screen. Okay, is it good now?
Yeah, all good now.
Okay. So, as I said, so diabetes is mostly of two kinds. One is diabetes type 1, that's due to the insulin deficiency. And that's about 5 to 10%. And the type 2 is about 90 to 95%. That is due to can be the overproduction of insulin in the setting of insulin resistance. There are also the other kinds of diabetic peripheral neuropathy that can be a genetic defect in the insulin. And at the same time, it can be a genetic defect on the peripheral receptors. As we are familiar with, other systemic diseases can cause the diabetic peripheral diabetes. That includes like cystic fibrosis. And we also sometimes see the other kinds of diabetes, that's gestational diabetes too. Other than diabetes is basically is very common. You can imagine that, see that about 400 to 425 million people enrolled for diabetes. And diabetic peripheral neuropathy is the most prevalent, debilitating, and costly complication of neuropathy. Given that number of patients with diabetes, you can imagine that's a potential health implication on a society or on an individual level. Even if we include a pre-diabetic condition, plasma glucose, and in that case, then there are estimates that about 1 billion people in the world have a pre-diabetes, and 1 in the people in United States are pre-diabetic. The American Diabetic Association's definition for pre-diabetes includes basically a fasting plasma glucose is from 100 to 125, and diabetes, radiculoplexus, neuropathy, and treatment-induced neuropathy. Then it comes also the mononeuropathies that includes cranial and peripheral neuropathy. And in addition to that, then autonomic neuropathy, depending on which organ is involved. And then there is a 5th types of neuropathy, that's a CIDP associated with peripheral neuropathy. The most common neuropathy is the diabetic polyneuropathy. That's what we are going to discuss today. As I said, the prevalence is easy to interpret based on the studies, but if we look on the studies, the prevalence is a symptomatic neuropathy. One is about 10 to 34%, and type 2 is 8 to 25%. If we include symptomatic and asymptomatic, then it goes to, in type 1, about 55%, and type 2, it's about 45%. If we take an incidence, so you can see on the numbers here, in type 1 is a 2,800 per 100,000 person years, and in type 2, it is a 6,100 per 100 person years. What about the prevalence in a pre-diabetic condition? That's roughly estimated is about 10%. There are studies that have looked on the subtype of neuropathy that's we called a idiopathic neuropathy, that's basically encompassed close to the second after diabetic polyneuropathy. If we looked on those patients, and once they have a blood diagnostic test done that includes either glucose tolerance tests, so about 25% of those patients also turn out to be that they were pre-diabetic. So given that those 25%, you can imagine the number goes quite high, even in a pre-diabetic patients with diabetic axonal polyneuropathy, that what we discussed today. As compared to pre-diabetes, the control patients, the prevalence is about 2 to 7%. What about the age-specific prevalence that we can see? That does increase. For newly diabetic patients, they are about 8 to 3% at the baseline, and after 10 years, that prevalence goes up to close to 42%. As compared to non-diabetic patients, they are at the baseline 2.1%, and their prevalence after 10 years goes above 5.6%. we have other studies, that's longitudinal studies that have determined that in type 1 diabetes, the diabetic prevalence is about 20% after 20 years. But in type 2, because about 15 to 20% diabetic axonal polyneuropathies are diagnosed at the time of diagnosis. And within 10 years, that can go up to about close to 60%, the prevalence. But the other risk factor other than type 2 diabetes, other than hyperglycemia, the other risk factors are also hypertension, smoking, and hyperlipidemia in those patients. So what's the definition of diabetic peripheral neuropathy? Is characterized by symmetric numbness, paresthesias, pain, and weakness, which are predominantly in the distal parts of the lower and upper extremities. So the total estimated prevalence of common polyneuropathies that I put in this basically diagram, you can see is a diabetic polyneuropathy consists of the biggest number, that's about 32%, followed by idiopathic or cryptogenic axonal polyneuropathy that I mentioned earlier. But from this 26% group, there are about 10 to 15% patients turn out to be that they can be a pre-diabetic if they have either glucose tolerance test done for 2 hours. After these two groups are followed by toxic polyneuropathy, immune-mediated polyneuropathy, hereditary, and along with the other groups, as you can see. Then moving on to what is the potential risk factors for peripheral neuropathy in diabetes. In type 1 diabetic polyneuropathy, although we know that there is a prevalence about close to 50% in both types of diabetes for the diabetic polyneuropathy, but they are two different diseases, and their pathophysiology is even also different. There is a direct link between hyperglycemia and diabetic polyneuropathy in type 1. It has been proven from the literature that hyperglycemia is the only risk factor in type 1. And with the optimization of the glucose control, the relative risk of diabetic peripheral neuropathy can be decreased close to 75 to 80% in type 1. Compared to type 1 and type 2, hyperglycemia is a major risk factor, but its contribution in the development of peripheral neuropathy is not as significant as in type 1, given that basically intense control of hypoglycemia in the studies have showed the reduction in the development of peripheral neuropathy can only happen about 5 to 9% as compared to close to 75% in type 1. And the main reason for that, there are other vascular risk factors that, as I put it over there, that's mainly included hyperlipidemia, hypertension, and smoking. They have been proved that they are independent risk factors for the development of peripheral neuropathy in type 2 diabetes patient. Then moving on to the clinical presentation. The clinical presentation of diabetic peripheral neuropathy depends on its pathophysiology, and that is the dying back mechanism of axons. So it basically starts with the dysfunction of axons depending on the length, and that's the reason that its other name is also the length-dependent generalized axonal polyneuropathy associated with diabetes. The most common symptoms with the clinical presentation in diabetic patients is a pain. It has shown that the pain is about close to 30 to 35% a symptom with the patients of diabetes, peripheral neuropathy. And the reason for that is that the peripheral neuropathy basically in diabetic patients start with the small unmyelinated nerve fibers that carry the pain sensation, light touch, temperature. And that pain can be moderate to severe in intensity. And that is one of the common symptoms that bring the patients to the physicians. There were studies on that shows that the pain severity had shown about on pain scale of 10, mostly patients labeled that close to between 5 to 6 of the intensity. It can be a different characters. It can be a burning. As you can see, buzzing, tingling, paresthesias, those are the positive sensory symptoms, followed by also the negative symptoms, hyposthesia, numbness, gait abnormalities, such as ataxia. Then it's followed by the motor symptoms. The positive motor symptoms includes cramps, twitching, myokemia, weakness, fatigue, wasting. And also patient does report difficulty differentiating from hot to cold. There is also symptoms from the autonomic involvement that includes impotence, urinary incontinence, abnormalities of sweating, lightheadedness, skin color changes in the distal part of the lower extremities with atrophy, hair loss. Also, the peripheral neuropathy can cause impairment in daily activities of living, like handwriting, problems fastening jewelry or buttons, inserting and turning keys, tipping on a carpet or a curb. With reference to exam and the motor exam, when we see the patients, fibers are involved, then you can see there's a weakness, but the weakness is mostly minimal. You can mostly in the distal muscles of the lower extremity, small toe flexion extension, EHL. You can see, and in a neutral position, mostly shin and unsupported ankle should be approximately 130, but in diabetic patient, it can be more than that. And also in the hand, you can see second and fifth digit abductor can be affected with the motor weakness. The large fiber assessment can be done. That includes vibration, joint position, and Romberg sign. And small fiber assessment mostly is done by pinprick temperature, light touch sensations. The most sensitive way is to check a vibration with the 128 tuning fork. And for the light touch, you can assess with 10 gram monofilaments sensations assessment. What about the gait abnormalities? They are subtle weakness. It can be toe, heel, tendon, to tendon. What are the complications of neuropathy? As a foot ulceration, and is a common complication. It has seen that diabetic polyneuropathy can increase the foot ulceration about 7-fold. That foot ulceration and diabetic polyneuropathy contributes about more than 60% of lower extremity amputation, and its part of reason can be due to the peripheral neuropathy along with a poor peripheral vascular disease, and also loss of sweating and loss of healing due to the autonomic involvement. The other common complication that shows that about 1/3 of the patients over the age of 55 with the diabetic polyneuropathy had a fall and lost 1 year or so. What is the diagnostic evaluation for peripheral neuropathy? Getting a diagnosis for peripheral neuropathy early on is very important. It gives an opportunity to the clinician to implement the strategies that can reduce the complications. That includes fall, and also to advise the patients about the education of diabetes and of their foot care so they can avoid the foot ulceration and ultimate amputations. The other good reason to have early diagnosis for polyneuropathy can be that when the diabetic polyneuropathy starts early on, the pathophysiology can be reversible, and with a certain measures that can be reversed once it involves to the axonal degeneration, and after that, the changes are almost irreversible. Diagnosis can be done based on clinical presentation, on assessment, as I discussed earlier with the clinical presentation. They have done a study that shows that a community neurologist was able to diagnose about 65% accuracy the diabetic peripheral neuropathy. When those patients were seen in a neuromuscular center, the neuromuscular specialists or the peripheral neurologists are added about 10% more diagnosis.
Hello, doctor.
Hello? Can you hear me?
Yeah, unfortunately, looks like there's an internet
What about
problem.
now? Can you see
Yeah,
the slide?
the slide is gone. Can you reshare it?
Oh, you cannot see it?
Cannot. Please share it again.
Okay, 1 second. I'm sorry. Can you see the slide now?
Yeah, I can see it now.
So you wanted
Please,
me to put on full screen?
yeah, full screen, please.
Yeah, okay, sure. 1 second. I'm sorry. I apologize for this technical issues.
That's
No
okay.
So
worries.
basically, I hope that I was not disconnected for long. So I was talking about the diagnostic evaluation. So with the Toronto Consensus Conference in 2009 came up with these new criteria. Based on that is a confirmed diabetic symmetric peripheral neuropathy is the patient should have signs and symptoms along with abnormal nerve conduction studies. Probable clinical diagnosis includes both signs and symptoms, but they does not need to have abnormal nerve conduction studies. With the possible clinical diabetic peripheral neuropathy requires either one of them, either symptoms or signs. Can you hear me now? Yeah?
Yes, we can hear
Yeah,
you.
okay. So what about the lot of pre-diabetic peripheral neuropathy and even diabetic polyneuropathy also starts with the small fiber neuropathy a lot of times. With pre-diabetes, the peripheral neuropathy's presentation is almost mirror image for the diabetic polyneuropathy, except that given the small fibers are involved mostly, so their initial presentation about 80 to 85% is with the pain. With reference to diagnosis for small fiber neuropathy at this stage, we have 3 objective testing we mostly perform. That includes a skin biopsy that has been well recognized by that Toronto Consensus Conference, quantitative pseudomotor axon reflex testing if it's available, and also the TST testing. Moving on to the role of the electrodiagnostic studies in MRI, brain, or spine for the diabetic peripheral neuropathy. Those tests, most of the time, do not add much, especially MRI of the brain and spine, do not add much, but it does add a lot for the cost. There was a study done that looked at the typical presentation of patients with diabetic polyneuropathy who have EMG nerve conduction studies done. Out of 458, there are about 2 patients, their management was changed. EMG nerve conduction are important role in atypical features that includes asymmetric onset, acute onset, early motor involvement. In those cases, the EMG nerve conduction studies can be very handy, a diagnostic, and can change the management significantly. What about if we do EMG nerve conduction study? Mostly the findings, what we see with diabetic polyneuropathy, that's have either reduced or absent sensory responses, and also reduced motor responses with mild slowing of a motor conduction velocities. And sometimes also we see sensory nerve conduction velocities, mild slowing, but not in a range of demyelinating severity. What about once we have diagnosed the patient with diabetic polyneuropathy, given that the prevalence of diabetes, as I said, it can be that high, about 10% in the United States, more than 400 to 425 million people all over the world. Those patients also have another additional associated or independent reason for diabetic, for the peripheral neuropathy. There was a study done, they have looked at the patients who were diagnosed with diabetic peripheral neuropathy, and more than 50% of those patients have another cause that was contributing, and mostly the main cause, about 50% of those times turned out to be a heavy alcohol use, and that can be diagnosed even based on only history. That followed by vitamin B12 deficiency and also the paraproteinemia. There are certain cases that autoimmune or the infectious cause like hepatitis C or HIV can play a role too. And in certain cases, having those diagnostic tests done also helpful to see if there's any additional or the contributing factor. What are those labs that needs to be done in those cases? The labs other than done to find out the other contributing or the independent cause, that includes vitamin B12 with methylmalonic acid, serum protein electrophoresis, and comprehensive metabolic panel. In certain and selected cases, is HIV testing and hepatitis C testing can be helpful. And rheumatology and thyroid testings are mostly low yield for peripheral neuropathy diagnosis. So what about moving on to the pathophysiology? The pathophysiology of diabetic polyneuropathy is not completely well known at this stage. The etiology at this point is thought is that it's a multifactorial. It can be a different metabolic mechanisms that includes accumulation of glycation end products, oxidative and nitrosative stress, abnormal flux of calcium regulation, and increased polyol pathway. Metabolism of sphingolipids into a toxic deoxysphingolipids also playing a role too.
We just run out of time, Dr.
Yeah, this is my last slide. So
okay.
Hyperglycemia and hyperlipidemia cause inflammation, mitochondrial dysfunction, and oxidative stress, which result in the neural dysfunction, impaired axonal transport, and damage, direct axonal injury. Nerve ischemia also plays a role in diabetic peripheral neuropathy, including endothelial injury and microvascular dysfunction, nitrous oxide mediated microvascular reactivity, and microangiopathy. Thank you very much for listening to me. And
Thanks,
these are my references here. And I hand over back to Dr. Abubaker.
Thanks very much, Dr. Zulfiqar. Excellent topic, as expected. The next topic would be run by Dr. Mazen Dimashqiya, who is a professor of neurology and director of neurophysiology and neuromuscular department at University of Kansas. States. He had his residency and fellowship in States. He's a well-known author and co-author in many neuromuscular publication. His main interests in research are in ALS, neuropathy, myasthenia gravis, and myopathy. Dr. Professor Dimitri's topic today would be updates and treatments of diabetes neuropathy. Microphone is yours.
Thank you, Dr. Al-Madani. Thank you for this kind introduction and for the invitation. Can everybody hear me okay?
Yes, we can hear you.
Thank you. Delightful to speak with everybody here. I see like over 1,000 people joined, anywhere from physicians to nurses to different professionals. So welcome. Let's talk about updates of diabetic neuropathy. I think the previous speaker has laid the grounds very nicely about what diabetic neuropathy is. I'll try not to go over that one more time. So let's go through some kind of the slides that I normally present at meetings. I've been doing research for the last more than a decade now, and I've been involved as a consultant or a study site PI with different studies. And none of those potential conflicts of interest will interfere with my ability to give you an unbiased discussion about the update on treatment of diabetic neuropathy. Just for the nurses in the audience, neuropathy is a very common problem. I tell my patients in the clinic, it's the most common problem nobody has ever heard of. It affects a large proportion of the population, but focusing on diabetes and looking at a decade-old data from the US, there are about 26 million diabetics, and 1 out of 4 have painful neuropathy. That's a large number of people, in excess of about 8 million people, right around there, that are diabetic neuropathy sufferers. When we did this study comparing causes of neuropathy, this is a biased review because it is at large academic centers from North America and South America. There was about 1,000 patients in each of those subgroups, and diabetes was a big one, a leading cause. But this is from an academic medical center standpoint. Now, the folks in the Netherlands looked at causes of neuropathy and frequency of neuropathy. And it turns out if you are very strict and look at definite neuropathy only, about anywhere from 4.5% of women and 6.5% of men have neuropathy, which is pretty frequent, as you know. Now, when for causation, notice this, diabetes. 31% of all neuropathies were diabetic. In this study, about 46% were without known risk factors, meaning cryptogenic sensory neuropathy, making diabetes could be number one, but in this study, it was the number 2 cause. I know earlier on we heard it could be number 1 cause. It depends on the local population. This is the Dutch population. Now, I'm not going to repeat all this because a lot of this was presented earlier, except to indicate from this study from Mayo Clinic, Rochester, looking at peripheral neuropathy in people with diabetes, it turns out that the majority of them have 1 or more neuropathy. So patients with diabetes can have more than 1 neuropathy at the same time. The most common, and this is where I'm going to focus the rest of the conversation, is what we call distal symmetric polyneuropathy, also known as DSPN. And you can see this is more than half the patients in this cohort had distal symmetric peripheral neuropathy. There's median neuropathy, which is sometimes clinical, sometimes subclinical, autonomic. There's this asymmetric proximal neuropathy, that's the diabetic myopathy that was earlier discussed, and there are other variants there. Now, one quick point about impaired glucose tolerance, because initially we thought that impaired glucose tolerance was a cause of neuropathy, and then the concept evolved to thinking that this is a cause of painful neuropathy. However, over time, we got to understand that while doing an OGTT, an oral glucose tolerance test, is much more sensitive than A1C or straight up fasting glucose, for detecting any of those conditions, including impaired glucose tolerance, the key link from that, meaning impaired glucose tolerance, prediabetes, to development of neuropathy is this, the metabolic syndrome. Metabolic syndrome is someone who has not only prediabetes, but waistline obesity, they're overweight, someone who also has hypertension, and importantly, dyslipidemia. Smoking doesn't help matters, of course. So from here on, I'm going to focus the rest of the conversation with this brief introduction on the management, the update to the management. And we're going to have a four-pronged approach. We're going to talk about slowing progression of the disease by treating the underlying cause, diabetes itself. Second, relieving pain, whether with pharmacological or non-pharmacological intervention. Third, managing complication and restorative therapy, physical therapy, what's the role of that? And nerve repair and growth, which is where the hope is, but we're not there yet. Please write your questions in the Q&A section as you have been doing. Now, this is evidence that is very strong that we have in type 1 diabetes, as was alluded to earlier. Tight control of diabetes based on the diabetes complication and treatment trial, the DCCT trial, shows that the benefit of early, tight, strict control of diabetes in type 1 diabetes, remember type 1 is the small minority of diabetic, 5%, 95% are type 2. But in those patients that have insulin-dependent juvenile onset diabetes, type 1 diabetes, those are the benefits extend to many years out in the way of prevention of the formation of neuropathy, and the neuropathy is less severe. Now, this is from a Cochrane review that was published 8 years ago, not only highlighting the same point, and maybe someone does not have their microphone muted. We're hearing a little bit of background noise. If you please could mute your line, that would be fantastic. Thank you. Now, this reaffirms what we already shared right now. Type 1 diabetes, no brainer, tight control, very good. With type 2 diabetes, in this Cochrane review, it shows that the p-value to indicate that tight control reduces the frequency of clinical neuropathy in diabetes, it was close to significance. It was a trend, but not quite there. However, nerve conduction velocity reduction, vibration abnormality were improved in patients who got tight control for their type 2 diabetes. So it's still a recommendation regardless of type 1 or type 2 for tight glucose control. And it's important to keep in mind that tight glucose control doesn't mean we kill the patient, because if we're throwing the patient in hypoglycemia, that can be life-threatening. So it's important that we avoid the risk of severe hypoglycemic events, which should be taken in consideration when you're talking to the patient about tight glucose control. So what does it mean, tight glucose control? How tight? Well, it depends on the age. If it is someone who is under age 59, then this is the range 80 to 120, around 100, whereas you're a bit more liberal in someone who is over age 60. But it's not just the blood glucose to slow down the progression. Like I said, those other comorbid factors also have an impact on the development and progression of the neuropathy. Blood pressure, eating plan, plenty of physical activity, healthy body weight, stopping smoking, avoiding alcohol. And it turns out we have more data. So the data that we have just came out earlier, a month ago this year. And this is from the Journal of the Peripheral Nervous System, which is one of those important journals for neuropathy. And this is looking at what happens in people who are 60 years out into their type 1 diabetes. What makes it where they don't have a development of diabetic neuropathy? Why is it that they don't? It turns out that the only factors that could distinguish type 1 diabetic many, many years out for reducing the risk of development of neuropathy were their lipid profile and their alcohol consumption. So that's something important in type 1 diabetics. You tell them on the long term, it's important to follow every healthy habits, but especially lipid profile control and alcohol consumption. Now, we're going to touch on neuropathic pain. We cannot talk about management of peripheral diabetic neuropathy without talking about pain. We all know what pain is, but there's a variety of healthcare professional. I think that there are different types of pain. There's inflammatory pain, soft tissue pain, someone with arthritis, with swelling of the joints, they're red, they're warm. That's arthritic pain. That's different from trauma pain, soft tissue injury pain, someone with the broken humerus bone, that's also pain. But neuropathic pain is different. The neuropathic pain has qualities to it that distinguish it. In the absence of local swelling, in the absence of soft tissue injury, there's a pattern to this pain, meaning it seems to be, instead of worse with activity, which is common to injury pain, it is worse with rest. People sit down, now they feel the pain when they have neuropathic chronic pain as a result of diabetic neuropathy, for example. It's worse at night. It's less with activity. So the type of pain quality also is important. It's not just the dull, aching pain. It's either electrical pain, shooting pain, or burning pain. So if you have that constellation of symptoms, then you're thinking the pain is neuropathic, and treating it as neuropathic pain is important. Now, the other thing that I want to bring up is that oftentimes, imagine this. You have pain that burns, shoots through your body unpredictably at night, during the daytime. What happens to you emotionally? You're highly likely to be anxious, even depressed. And for that reason, it's important when you are evaluating neuropathic pain, you establish this is neuropathic pain, ask about whether there is a comorbid psychological component that occurred as a result of the pain. Because the drugs we have different mechanism of action. If someone is anxious or depressed, you may use a drug with a combined pain modulating property, but also antidepressant or anxiolytic property. So from a simple management standpoint, someone with sensitive feet to touch, oftentimes patients with neuropathy will tell you, don't touch my feet. As soon as you touch them, normal touch, just putting your hand on their feet will cause pain. This is an example of a patient who had to put this tent, this cradle, to prevent the sheets from touching their feet because that would cause them pain. That's called hyperesthesia, increased esthesia, pain to non-noxious stimulus. And so sometimes the solution beyond this are simple analgesics, anti-inflammatory agents, but many times it's not enough. So as I see the patients in the neuromuscular clinic, usually they fail those interventions. And I'm talking to them about pain that's been established for months and years. And it's important to set the treatment goals for pain. The pain score is extremely important. And we have here the visual analog scale. We have the Likert scale. They can circle the number. They can put a hashed line across that. That's helpful. But that should not be the only measure of success of treatment or severity of impairment from pain. The other components that are important to keep in mind is about interference in 3 of the key domains. So what are those key domains? We all are working right now. We need to work. We're learning as we're working. We all need to have recreation, fun with the family, going out there for a walk, or whatever activity is leisurely pleasurable to you. We all need to fall asleep and stay asleep without pain interference. So if a patient comes to me with neuropathic pain, my measure of success is a low level of pain. And what's low means a pain level that doesn't interfere with work, recreation, or sleep. Now, in clinical trials, the way that drugs are approved by the FDA in the United States for use, not that the FDA has, jurisdiction internationally, but at least I can speak on where I'm practicing. The way the drugs are approved is if they reduce the pain by 50% or more, 50% pain reduction. I want you to know in the clinic, if you track the pain score, that a 30% pain reduction is considered significant, meaningful, meaning if someone's pain score goes down from 7 to 5, this is not a failure, this is a success too. Now, it won't be any surprise to you that the type of drugs that we use for modulating pain are antidepressants, anticonvulsants, topical agents, analgesics. We dislike, for the most part, opioid drugs and discourage from them. This is from the American Academy Quality Measures Committee that looked at evidence in the literature for the management of diabetic distal symmetric peripheral neuropathy pain. There were initially a publication back in 2011. It was followed by an update in 2017. And this is the summary of that. It shows that level A and level B in my mind are the same group. Strong evidence that pregabalin, PGB stands for pregabalin. I apologize for the abbreviations. Amitriptyline, a tricyclic antidepressant, amitriptyline. DLX stands for duloxetine. Gabapentin, venlafaxine, sodium valproate, tramadol. They have morphine or oxycodone CR. I'm not a big fan, as I indicated earlier. Capsaicin, isosorbide dinitrate spray, percutaneous electrical stimulation, all have good evidence for modulating pain. There's some evidence of combining two drugs with a different mechanism of action. Gabapentin, a modulator of the alpha-2 delta subunit of the presynaptic calcium channel at the level of the dorsal horn, combining that with venlafaxine, a serotonin norepinephrine reuptake inhibitor. Lidocaine patch, I find it to be very useful in elderly folks that are sensitive to medication. Topical agent, especially when the pain is very localized to the feet. And there's some that we don't know if they work or not. Now, the update in 2017 was to add oxcarbazepine and low dose 5-10 units, different areas of the foot, botulinum toxin injection as effective, but with low strength of evidence, and was a call to arms for more long-term studies, more reporting on quality of life. Now, since that, in 2017, there's been an update that I wanted to bring to your attention to, and we're starting to implement it in our clinic. It's the use of capsaicin 8% patch. Now, in the US, capsaicin 8% has been approved for years now for the treatment of post-shingles pain, post-herpetic neuralgia. However, here recently in October, I believe this year, the US FDA approved the use of 8% capsaicin patch for painful diabetic neuropathy. Yes, painful diabetic neuropathy. It's usually applied for a less period of time, 30 minutes in diabetic painful neuropathy. They could be as much as 4 patches applied, and it's repeated every 3 months. And the way it works is that the TRPV1 receptors in diabetic neuropathy starts firing at physiologic temperatures of 38 degrees Celsius. The TRPV1 receptors, what they do is they release substance P. Substance P induces pain. So if there's a way for you to give an agonist like capsaicin to the TRPV1 receptor and release all of the substance P, you will cause intense pain. That's why you apply EMLA cream initially. But once substance P is depleted, it induces an analgesic state. And that's why it's FDA approved, something to keep in mind in case it's available in your countries. There are other treatments that are non-pharmacological. We'll talk about physical therapy a little bit more, but that's important. The podiatric care, some patients with just changing the shoes that they wear will just be able to cope through the day and not have as much difficulty. Sometimes they Google online neuropathy socks and they find the perfect socks that work for them. Sometimes it's a matter of pain psychologist seeing the patient, or cognitive behavioral therapy instruction, or TENS unit, or biofeedback and relaxation response. I suggest this book typically. I've heard of patients having benefit from acupuncture, foot massage, supplements, but not too much B6, because we know doses of vitamin B6 more than 50 milligrams can induce neuropathy. I've had a physician, I run a national course in neuromuscular disease, and we actually have international audiences in them. And I had one physician from Pakistan tell me about their experience with henna, that some patients with neuropathy that they've had responded to henna. So I'm always looking for remedies that patients and physicians tell me about that have worked for their neuropathy pain patients with diabetes. Now, from a restoring the function, this is a study that we did at the KU here, a pilot study showing that resistance and aerobic exercise for a period of 10 weeks improves pain and improves neuropathic symptoms, and it increases the branching of nerve twigs when you do a skin biopsy on the upper thigh area. And there's a correlation between that and the change in pain score. So that sometimes when you tell the patient exercise, they have the wrong idea. You tell them exercise and they think, well, I'm going to go to the fridge and open it up and close it. And every time I bend my elbow, that's exercise. And I want to walk to the fridge and come back and sit down and eat some more. It's exercise. Well, that's not good enough. It has to be high intensity exercise. It has to be more than just this regular activities. Have you heard the expression, sitting is the new smoking? It's basically standing desks are fashionable nowadays because exercise, even standing as an exercise, is helpful to your health. So as part of that thought of process, we are involved in a two-site study between Kansas and Utah, looking at exercise as an intervention in people with diabetic neuropathy. It's a long-term study. It's a 5-year study. It's NIH funded, and it's a single-blind study of enrolling 140 patients. So hopefully in the next few years, we'll have answers towards that study. There's some things that are controversial. I know there are pain specialists in the audience. Some will speak. There's not enough data on interventional regional anesthesia, so that I usually discourage my patients from doing that. Spinal cord stimulation, there are research studies going on right now, and I think it should be tested in the context of a research study. There's something called anodyne. I'm not sure if you have access to it, but it's near infrared light therapy, which liberates nitric oxide. Nitric oxide releases oxygen and vasodilates vessels. And some patients benefit from it. And I usually don't have too much issues with it, but because the device is costly, I send them to a therapist to do a session that's cheap. And if it works for them, I tell them, sure, buy the device. Peripheral nerve decompression, that's a problem. There's a school of thought that nerves in diabetes are compressed. If you decompress them at the foot, at the arm, at the elbow, at the knee, that patients will do better. Studies have been done. It's been a decade ago that they've been completed. No results have been published. That tells you something. That tells you you should caution your patients. They should not do this. They should not have decompression. Now, so what can you do as far as a repair and regrowth as a part of treatment update? There have been several trials of aldose reductase inhibitors, and aldose reductase is one of the issues with diabetes, as you know. However, there's been no success. Alpha lipoic acid, there's good data on IV working, but the oral has mixed data around it. I have some patients taking orally alpha lipoic acid. It's something you can consider in your patients. It's available over the counter, at least in the US, hopefully in your location. Acetyl L-carnitine, there's 4 different studies. One of those studies showed that there's reduction of pain and improvement of in nerve fiber density in the sural nerve. However, a Cochrane review that was published last year showed that there's not enough support for that. But acetyl L-carnitine is over the counter, something that you can consider trying with your patients, like alpha lipoic acid. No guarantees of success. It may have some analgesic effect at best. Magnets have been tried. They've been encouraging data early on, putting a magnet inside your shoe, like an insole, and then walking around with magnets. But then the randomized control trial was negative. Even nerve growth factor injected under the skin had promising data in phase 2, but failed in phase 3 studies. Now, this is something that we already know we can do. We've known for a while that there's kidney pancreas transplant that can be done in people with type 1 diabetes. And this is data looking at what happens if someone gets a transplant 3 years out. And they did look at different things, measures of pain, impairment. They looked at also skin fiber density, but also at corneal confocal microscopy. And by that method, they can identify and measure the number of nerve twigs in the cornea. So let's see what they found out. This is again published last year in Diabetological. I thought it's important to bring that up. As I was preparing this talk for this audience. There's over 36 months after kidney pancreas transplant, there's increased fiber density in the cornea. Neuropathy symptom profile improves. The peroneal nerve conduction velocity also improved. Also in the skin, even though it didn't get better, it didn't get worse, it stayed the same. And there was some improvement in some of the other features called dendritic length. So in brief, you expect to see some changes, positive changes as a result of transplant in the nerves, in the limbs, as well as in the cornea. But where it lags basically is in autonomic symptoms. These tend not to improve. For example, cardiac autonomic function assessment, that did not improve. Now, going along the lines of experiments targeting modification of the disease, there's a drug called SB509. And what SB509 is, induces vascular endothelial growth factor type A, and is neurotrophic and neuroprotective, meaning it grows nerves and protects nerves from injury. Unfortunately, a phase 2 study was negative. There's a drug called VM202. We were part of this SB509 study. We're also part of that VM202 study. It's a DNA plasmid-based gene therapy that's intramuscularly administered in the calf muscles. And it encodes for something called human hepatocyte growth factor. And what it does, it promotes regeneration, and the primary target of the study is to demonstrate that it alleviates pain. However, the study was completed and it was reported as negative. But one of the issues was that some of the DNA material that was supposed to be not in the placebo patients, meaning some of the vector material, that the genetic material of the VM202 was found even in the placebo. So there may have been a mix-up at some of the sites in the administration. And I think a follow-up study is right now in progress. So to conclude, I think diabetic symmetric peripheral polyneuropathy is the second most common neuropathy, probably after cryptogenic sensory neuropathy. It could be number one in other countries. Distal symmetric neuropathy is associated with pain, and it's a challenge actually. But one thing to remember is when someone comes to you with distal symmetric neuropathy and pain, they should not be in a wheelchair, meaning they should not have severe weakness where they're in a wheelchair. They should not have disabling ataxia. Now, if they have sensitivity to their feet to standing up, that's understandable, but they should not be in a wheelchair. If I see that, I'm thinking something else is going on. Therefore, but from the pain management standpoint, discuss the expectation, the three domains that are important. We have work, recreation, and sleep. And that's called success. A mild pain that doesn't interfere with those is success. Otherwise, if someone's expectation is zero pain, then they'll become a zombie. They'll be sleeping all the time. That's not really realistic. And there's several different pain modulating drugs. So you select them based on not only efficacy, and we know many are efficacious, but their adverse event profile, their side effects, comorbidities of the patient, depression, anxiety, or not. And so we have the advantage of multiple drugs with mechanism of action. For the time being, for people with diabetic painful neuropathy, optimal glycemic control is important. Good health habits, lipid control, blood pressure control, not drinking alcohol are important. Symptomatic care, we talked about pain modulating drugs, and then physical therapy. And I think there's promise in that physical therapy and exercise is going to be the way to go. while we're waiting for more disease-modifying therapies to become a reality. So at this point, I will stop here. This is my presentation. I'll stop sharing the screen. Thank you for the time.
Thank you very much, Dr. Dimashqiya, and excellent notes, an excellent topic as usual. We can have only a few minutes question. Most of the question you already answered in the slides. One of the interesting questions is sensory neural deafness. Could sensory neural deafness be due to diabetes neuropathy?
Dr. Zulfiqar can provide it.
Can you hear me?
Yes, you can.
In a very rare cases, maybe, but that's not even a common presentation at all, not to my knowledge.
Okay. One of the questions here, what's the best medication you use for painful neuropathy in your opinion?
Well, it's a group of medications. This is the level A and level B recommendations. So typically, these are the tricyclic antidepressants, pregabalin, gabapentin, duloxetine, tramadol. All of these are in the first-line agents that are highly effective. So you look at comorbidities. And one of the things to keep in mind is you start on low doses and build it up slowly so that the patient does not have side effects and refuse to take the medication anymore.
One of the questions here, someone who's taking metformin, and according to him, the metformin may decrease B12 level. And in that case, may cause peripheral neuropathy. Do you recommend B12 regularly for those patients who are taking metformin?
I've heard of that and I'm familiar with it, and probably Dr. Zulfiqar Hussain is also familiar with it.
Yeah.
And I think getting a yearly check of vitamin B12 is a good idea if someone is on metformin. Dr. Hussain, do you have a different perspective?
Yeah, no, I do the same by checking B12 and methylmalonic acid with our homocysteine if kidney functions are normal, and in case if B12 is under low normal range.
There's someone who's very fond of honey. He's asking, can we give honey to patients with diabetes?
Well, I mean, Dr. Hussain, I'll let him answer this one.
Yeah, but you know, obviously there's not a lot of literature about honey and use in diabetic patients. But I don't have any definite answer for that. But on my personal recommendation that I wouldn't use it excessively.
Okay. The other question is here.
I would add to it just simply something. Maybe it's now with the advancement in glucose monitoring, where you can have this device on the back of your arm and you have minute-to-minute glucose measures. I think that if you're gonna do honey, probably make sure that it's not throwing your glucose out of crazy control. But generally speaking, I would think that would be a good carbohydrate load right there, you know. And so it would be something to approach with caution, as Dr. Hussain mentioned.
One of the audience is asking your own experience with capsaicin patch in diabetes polyneuropathy.
Well, I think that our experience is so far young because we just are treating our first patient this week. So unfortunately, I cannot share with you my personal experience, but I think it's a procedure altogether, meaning that the patient will be in the office for about half an hour to an hour. First, they have to have a local topical analgesic, the EMLA cream, because otherwise the skin will burn and itch so much when you apply it. So they have to first apply the EMLA cream for 20 to 30 minutes. After that, you apply the patch and you have to leave it there for a period of time, half an hour, and then you remove it. So it's an hour visit in the office to do that. And so, but yeah, something that I think will help, but I don't have the experience to respond to that question.
One last question over here. Can diabetes polyneuropathy injury cause ulcer and foot sore?
So
The answer is yes.
Yes.
That's a very common complication, obviously, especially in patients who have a asymptomatic diabetic symmetric polyneuropathy. And there's a good number of patients are they are asymptomatic if their pain is not the presenting symptom. And that's the reason the recommendations are a regular checkup, and maybe patients should have a regular follow-up with the pediatric foot clinics, and have education about the foot ulcers, and regular exam for the patient themselves to have it.
We hereby conclude the scientific part of the talk. Thank you very much, Dr. Zulfiqar and Dr. Dimashqi, for your speaker would be Dr. Wa'il Mustafa. Go ahead, Dr. Wasim. So he's going to be talking about access healthcare.
Can hear you.
Okay. First of all, I'd like to thank Dr. Abubaker and the CMO company for organizing this meeting. I'd like to thank Dr. Mazen and Dr. Zulfiqar for those valuable information. In the coming few minutes, we'll speak about dietary support to relieve neuropathy. Mainly, we'll focus about 2 points. Some of the points have been mentioned in the lecture or the presentation of Dr. Zulfiqar and Dr. Mazen as well. So it's a good support for us as well. The 2 points mainly will focus about a recent published article about in clinical pharmacology 2020 about the meta-analysis study about the medicines or the medications.
Sorry to interrupt you, doctor. Can you go on full screen?
About the medications that causes peripheral neuropathy. And the second point that we'll focus about it, which is the ultimate and safe supplement that we can use. And I think Dr. Mazen highlighted that in his lecture. If we look for, we jump, of course, something everybody knows about the neuropathy incidence in our population, especially in the Middle East here. 2.4 of the population are suffering from peripheral neuropathy, and the prevalence increased to 8%. If we look for the etiology of the neuropathy, we'll find, of course, as you know, diabetes, trauma, autoimmune disease, vascular disorders, and some medications that will focus about it in this presentation. For diabetes, 60 to 70% of diabetic patients are suffering from, according to the studies, they're suffering from peripheral neuropathy. If we look for the other hand about the medication, which is our focus in the first part of our medication, we'll find that heart or blood pressure medications, cancer medication, and infection disease medication, skin conditions also as well. In the recent study that has as a meta-analysis has been published in pharmacology, current clinical pharmacology in 2020. I will focus mainly about the medications that we are using as a doctors in daily basis. We're prescribing it for your patients. One of them are the statin group, which is for hyperlipidemia. They found that the incidence of peripheral neuropathy reached to 4.6%, which is considered to be a high percentage compared to others. One of the other product as well, which is amylodarone, which is cordarone, everybody knows about it. It depends on the case itself. It reached to 38% in some of the patients. Anti-infectious diseases like metronidazole, everybody prescribing everyday metronidazole. They found that 10 to 85% of those cases of those who get metronidazole, they suffer from peripheral neuropathy as well. Some other items or some other ingredient medication for TB and community-acquired pneumonia. The number is higher than that. And for arthritis pain, also there is leflunomide, which reached to 5 to 10% of the as a peripheral incidence of peripheral neuropathy. Now we'll go for the second part for the how we manage that. It's a part of the lecture of Dr. Mazen. In fact, we have upgraded the formula of vitamin B complex, okay, by adding some new ingredient inside it. As you know, that vitamin B complex is very important, as for the last question for Dr. Mazen regarding the vitamin B complex, how much it is important supplement, okay, to compensate the loss of vitamin B inside the body. Okay, we added also vitamin D. We added alpha lipoic acid, which is highlighted by Dr. Mazen in his lecture, feverfew, oat, passion herb, skullcap, and L-arginine. We'll go quickly about the ingredient, how much is this formula is upgraded from the traditional vitamin B complex, which is available, okay, in the right now. We'll find that vitamin B1, it's a very important neurotransmitter, which improve the psychological function. Vitamin B2 improves the metabolism and helps the body to produce energy. We'll jump to number 3, which is vitamin B12. Okay, our product also including methylcobalamin, which is the active ingredient, okay, or active form of the cyanocobalamin. Okay, vitamin B6 is very beneficial for nerve and brain function. As upgraded for the formula, we added vitamin B9, which is a folic acid, helps to maintain integrity of RBCs and DNA as well. If we look for alpha lipoic acid, as Dr. Mazen said, it's very important. It's a potent antioxidant, proven relieving effect on neuropathy symptoms, numbness, stinging, sensation, and pain, regulates the distribution of glucose over the body. Vitamin D, which is available already in this upgraded formula, okay, it's a 500 IU, which is we need in our daily basis, supports the health and of the central nervous system, okay, and that has a big reflect on the relief of neuropathy for the patient. Improves the number 3, it improves the sensitivity to insulin as well. L-arginine, which is available in this upgraded form as well, amino acids that is converted to nitric oxide, which is powerful neurotransmitter and vasodilator that helps for better circulation, which remove the build-up toxins in the limbs. Some of the natural items that we included in this product or this formula, which is passion herb extracts, promote relaxation and mental wellness. Feverfew dry extract, it's a plant, as you see in the picture, relieves pain and inflammation. Oat dry extract soothes itchy skin and increased level of nitric oxide, reduces the inflammatory cytokines in the arteries. And Scutellaria dry extract, as you see in the picture, it is a plant, skullcap, known as a skullcap, increase the brain blood supply and promote the tranquilizer effect on the CNS, which has a big effect on the relieving of neuropathic pain. Okay, if we look here for the comparison of the traditional product of vitamin B complex compared to the new formula, as you see here, okay, we'll find that as a conclusion, okay, we'll find that we added here vitamin B9, which is not available in the current one, plus vitamin D, plus L-arginine, alpha lipoic acid, which is very important for diabetic patient, oat dry extract, Scutellaria extract, passion herb, and feverfew. Actually, as a conclusion, the dose of this one formula is 1 tablet, 2 tablets per day. It's natural nerve support for formulas that improve the patient quality life. Actually, this is the difference between better and much better. Your patient will feel what the meaning of better and much better for that when he get this one, this formula. drastically lowers the sensation of the burning, decrease numbness, of course, as a conclusion, decrease numbness and tingling in hands and feet, improve balance in elder patients, reduce stress and anxiety, helps to sleep better at night. Thank you so much for your time. And if you have any question regarding our presentation, I am ready. Thank you.
Thank you very much, Dr. Wael. We move the next topic now to Dr. Ammar Salti, I believe. And he's going to talk about Cutenza patch for treating painful neuropathies.
Okay, so good evening, everyone. I'm glad to be invited to talk about something that I use since 10 years now. So I'm going to share my experience for the use of topical capsaicin in painful diabetic polyneuropathy. As you can see, I work in Cleveland Clinic, Abu Dhabi as a pain physician. And previously I was in SKMC and Zayed Military Hospital. So my topic will be dealing with the diabetic neuropathy, polyneuropathy, and painful diabetic polyneuropathy. We know that 1 in 5 Europeans suffer from chronic pain in different etiologies, and the indication for capsaicin can be ranging from post-herpetic neuralgia, peripheral nerve injury, cancer-related neuropathic pain, and the topic for today is the painful diabetic neuropathy. Neuropathic pain affects more than 26 million people worldwide, and 60% of neuropathic pain is localized. And this is where the capsaicin is really indicated. For the painful diabetic polyneuropathy, which can reach 34% of the diabetic patients, capsaicin can play a role, and it is within the recommendations and guidelines. When we talk about the diabetic polyneuropathy, we talk usually about small fiber injury or somatosensory injury. Once we have this somatosensory injury, we know that there are some, we involve a lot of pain pathways, starting from the periphery towards the spinal cord, the brainstem, thalamus, and this explains these remodeling of the neuropathy of painful pain pathways, leading to these symptoms and signs that we need to look for when we look after painful diabetic neuropathy. And one of them is the allodynia. This allodynia is managed by something called capsaicin, the Cutenza, which acts on the TRPV1 receptors, the transient receptor potential vanillin 1 receptors. It's a selective agonist of the capsaicin is selective agonist of this receptor. It will be activating the inflammatory neuropeptide and increase the sensitivity to noxious stimuli. High concentration or repeated exposure of the receptors to capsaicin will reduce the painful sensation. Loss of function of nociceptive neurons and depletion of inflammatory neuropeptide, then producing analgesia. And this is what happens with capsaicin. It's a sort of defunctionalization of the epidermal nerve fibers, leading to pain reduction of in these patients. How it helps? It helps because it's rapid, clinically relevant pain reduction very early. Compared to oral medications, it can be as early as 1 week to be effective in focal localized neuropathic pain. For the allodynic area, which is the sensitization or the feeling of something which is not painful, which becomes very painful, this area is reduced by at least 10 to 15% in 1 week in first cycle. There is low risk of systemic side effect because there is no absorption or very minimal. So compared to the oral medications for neuropathic pain, we know that there's very little side effects compared to, for example, antineuralgics, where you have somnolence, dizziness, weight increase. For the capsaicin, we have just local effect with some irritation on the application on the skin. So very quickly, some data on the capsaicin for the painful diabetic polyneuropathy. We know that the neuropathic pain is increased during the course of the disease. Cadenza in peripheral diabetic neuropathy will lead to statistically significant reduction in the pain score from the baseline. This has been shown in this paper. Cadenza will be also affecting the quality of sleep in painful diabetic polyneuropathy, shown at from 0 to 12 weeks of the course of the treatment. Treatment satisfaction was significantly greater with Cadenza compared to pregabalin in this paper here, showing that patients are satisfied with the efficacy and with the reduction of side effects compared to pregabalin. For the guidelines, lots of guidelines since the 2010. We started our guidelines for treatment of neuropathic pain in the Middle East in 2011, and the Cadenza was already in the guidelines. The NUPSIC in 2015, neuropathic pain special interest group for the European societies has raised the capsaicin as a second-line recommendation. And very recently in 2020, these recommendations from the French group showing that capsaicin is established as one of the options for the diabetic neuropathy and focal diabetic neuropathy, as you can see it here. The Cochrane reviews also, as mentioned, that capsaicin can be one of the options, reducing the pain and the allodynia for these patients. It's 8% concentration, so very high concentration compared to what's in the market, 0.25, 0.025 for the normal creams. This is a complete different mechanism of action. It can be repeated every 3 to 5 months, applied for 30 minutes for diabetic patients, compared to other cases where 60 minutes are needed. We can have severe burning pain, itching, or erythema with application, which can be prepared with some EMLA cream if needed. We use a skin marker to cut the patch to treat the exact area. We don't need to have extended area above the painful area. The correct size nitride gloves is needed because capsaicin can diffuse through the latex gloves. Pressure is sometimes applied. I put sometimes some pads on the localized area just to help with applying. And the patient should be monitored, and blood pressure should be monitored also because sometimes it's increased. So to finish my very quick and presentation on the Cadenza, it's a strong and rapid pain relief for localized neuropathic pain. We have pain relief as early as 7 days, and it's long lasting. It's not only strong, it's long-term pain relief with one single application, reduction of allodynic area, and very, very safe with low rate of systemic side effects. We have many references for your kind attention if you need them, and I'm ready to answer all your questions. Thank you very much.
Thank you very much, Dr. Ammar. The one problem we face in private to get insurance approval on Cadenza and Versatis, which code you use?
Oh, which code do you use? I use actually my coders are doing that. So we use the neuropathic pain. So I use the neuropathic pain. It can be postherpetic neuralgia, it can be HIV infection, it can be post-surgical chronic pain. I treat a lot of these post-surgical chronic pain with neuropathic components. I usually present the DN4 as proof of neuropathic component present. For low back pain with neuropathic component also, I can use that. So we have some, I can't tell you exactly the numbers and then the figures of the codes, but neuropathic pain is one of the key components to be approved by the insurance companies.
Thank you very much, Dr. Ammar. We move to the next topic, which is going to be held by Dr. Tamer, and he's going to be telling us his experience about Viatris.
So, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I hope you're all safe, and thanks a lot for giving me the opportunity to be with you today. My name is Tamer Salab. I'm the head of Gulf Cluster in Viatris. Let me start by saying a big thank you for all the heroes around the call who have taken a lot of dedication and effort during this pandemic to keep us all safe, and thank all the eminent speaker for their very exciting and informative speech that they have given us today. Today, I'm very excited to share with you the story about Viatris, which is a new kind of healthcare organization with a clear objective where we want to improve our patient lives. This unique objective will be achieved through providing access to our patients, where we want to, I would say, improve or enhance our operations through leadership and developing innovative solutions. We want to leverage our collective competencies in order to drive partnership. Viatris has been created in November 2020, where it came from a combination of Mylan and Abjol, which is a division of Pfizer. We bring together best-in-class manufacturing capabilities, commercial capabilities, and distribution, where we want, at the end of the day, to improve, as I mentioned at the beginning, patient lives. Let's take a minute together to watch a video about Viatris and the creation of Viatris.
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.
So I hope it was clear from our branding that it reflects our drive to address the world emerging healthcare needs with passion and compassion. Viatris has been created with a very clear mission where we are saying that we view or we see the healthcare not as it is, but as it should be. And we want to create a source of stability in a world with an evolving healthcare needs. We want to achieve this through three passes. And back to the word Viatris, it is a Latin word that means three, which is the three passes: access, leadership, and partnership. We believe that those three can work together in a harmony to ensure that we really empower people worldwide to live healthier at every stage of their life. This is with the creation of Viatris. It's a new kind of healthcare company. From our unique business model and strong financial profile to our commitment to shareholders' return and social responsibility, we are positioned to create a difference for every patient, everywhere, regardless of circumstances and geography. Plus our unique offering of what's called Global Healthcare Gateway. This is aimed to create a fuel of growth to address unmet need in the healthcare system. We have a very diversified portfolio, almost 1,400 molecules across a wide range of therapy areas, starting from non-communicable diseases to infectious disease, which include best-in-class iconic brands. It includes generics and a very strong portfolio coming in the biosimilars, addressing different areas of focus like oncology, immunology, and ophthalmology, plus over-the-counter offerings in addition to APIs or what's called active pharmaceutical ingredients. This is also combined with what we call unparalleled global reach, where we have a very strong global infrastructure that is covering more than 165 countries. We are divided into 4 segments. What we have the developed markets, the US and Europe. We have the growth markets, which is covering more than 100 countries across the globe, that is operating here from the UAE, where our headquarters is being located. We have Great China, and we have what we call it Japan, Australia, and New Zealand, JANZ. We have a unique global platform that is comprised of almost 50 manufacturing sites. We have more than 2,500 scientists that are working together to provide more than 80 billion doses on an annual basis, from solid doses, injectables, and complex dosage form. Throughout these steps, we always keep at the heart of our work quality, and we are committed to quality at each stage and every stage, from development, manufacturing, up to distribution. Not only commitment to quality, but also are committed to our corporate social responsibility. We are committed to advancing responsible and sustainable operation, and we know that each action that we take can really affect the stakeholders around the world. And we want to make and to put a positive impact for patients, the global health, the global public health, environment, employees, and the communities where we operate in. We are inspired with the creation of our new company, and we want to work together to provide what we have, what we call empowering people worldwide to live healthier at every stage of their life. I would like to thank you so much for your time, and really encourage you to stay connected with us through our website, through our social media channels, and looking forward for our collaboration to stay ahead while bringing Viatris mission alive. Thank you so much. Stay safe, and back to you, Dr. Madani, for the closing remarks and questions.
Thanks very much. Thank you everyone for attending this sweet session tonight for 1.5 hours. It was a very nice talk from Dr. Zulfiqar, Dr. Mazen, Dr. Ammar, Dr. Tamer, and Dr. Waad. Thanks to you, all of you, and we hope we can cooperate in the next future. So thank you very much. Thanks. We conclude the talk tonight. I'll see you soon. Thanks.
Thank you so much.
Thank you.
Thank you very much.
Best.